So my patient, Mrs. Noreen, wife of Mr. Ahmed, she's 34 years of age with no formal education. She is resident of Kasur, married for 8 years. She is nulliparous. Her last menstrual period was on 9th October 2019. She is presented to Arif Memorial Teaching Hospital Outpatient Department on 16th October 2019 with complaint of inability to conceive for 8 years. The couple is married for 8 years. It is a consanguineous marriage and they are living together since the start of the marriage. They practiced barrier method of contraception for the first 3 months after their marriage, but later on did not use any. The coital frequency of the couple is 2 to 3 times per week, and every time the coitus is satisfactory with no coital difficulty and there is no history of dyspareunia or any post-coital bleeding. During these past 8 years, the patient and her husband have been through certain investigations as a part of their infertility workup. Husband semen analysis was done 1.5 years ago, and according to the patient, it was normal. However, the sperm count, motility or morphology was not known to her and report was not available with her. Her tubal patency was also done via hysterosalpingogram and she claims that she had patent tubes. She was tested for ovulation by ultrasonography in the mid of her menstrual cycle, and a blood test was also carried out on the day 21 of her menstrual cycle. The name of that test was not known to her, but she was told that she is producing eggs normally. Up till now, she has taken treatment in the form of ovulation induction, as she told that she had used tablets during menstruation from day 2 of her menstrual cycle for 5 days, and every time she was given the same drug with same dose, and she was asked to visit on the day 12 of her menstrual cycle for follicular tracking, and she was reassured that the size of the follicle is satisfactory. No further treatment options were discussed with the couple. My patient has no history of weight gain, acne or hirsutism. Her menstrual cycle is regular of 5 by 28 days with average flow. She used to soak 2 to 3 pads per day. There is no history of dysmenorrhea or any intermenstrual bleeding. There is no history of heat or cold intolerance. No history of headache, blurring of vision or any abnormal nipple discharge. There is no history of vaginal discharge, lower abdominal pain or fever. There is no history of any specific regular drug intake in the patient or history of chemo or radiotherapy in past. There is no history of sub-fertility in any family member, and patient had never undergone any surgery. Regarding her husband, he is 38 years of age, non-smoker, non-addict, owns a business of garments. There is no history of any medical illness, surgery, trauma or drug in him. Now the couple has presented to Arif Memorial Teaching Hospital Outpatient Department for re-evaluation and to discuss further treatment for sub-fertility. Regarding the past gynecological history, age of menarche was 14 years.
That's perfect. You can't have better history than this. At least I can't improve on this. They're perfect. Perfect. And that's how all of you should follow this pattern. If you get a patient of infertility in your examination, just take a photocopy of her history and revise it at home. This is the pattern you should follow. Because in this case, almost, we'll discuss further, almost all possible causes, possible treatments have been taken care of. She has inquired all about investigations which are possibly important for this patient, and they have done or not done, whether she knows the report or doesn't know the report, doesn't matter. It is your inquiry in the examination. Did you have tubal patency test done? Did you have hormones test done? Did your husband have semen analysis done? Just this fact. If the patient knows the report of that, it's okay, it's good. But even if she doesn't know, her husband's semen test was done, but she doesn't know the report. And she went into detail. I would like to know the total count, motility, morphology. These are 3 important factors. She mentioned that. And similarly, did you have any tubal patency test done? She might say no. Or in this case, she had hysterosalpingography done. And then on and on, she mentioned the only missing thing, one can always find little fault here and there. The only missing thing is that she did not mention the dates of these tests, because dates become important. This patient had been married for 8 years, practiced contraception only for first 3 months. It means practically they have been trying for a baby for 8 years. It's just possible all these investigations were done during first 2 years. And if she had those tests done 6 years ago, infertility of 8 years, and if she had these tests done initially, in earlier part of her married life during first 2 years, which could be normal. This is a normal thing. But no more investigation during last 6 years. A lot of things can change. For example, she had hysterosalpingography done, which was reported normal. But since then, she had some local treatment by a local midwife or local dye. And they usually instill some drugs or medicines locally which lead to infection. Or she was fine, in good health. Subsequently, tuberculosis has come back to Pakistan. She had pulmonary tuberculosis, and pulmonary tuberculosis gradually can cause infection of the genital tract as well, infection of the endometrium, subsequently salpingitis as well. So that could cause, although tubes were open, but since this disease came in, or the husband could have brought some local genital infection, and that could have traveled up and caused salpingitis and blockage of the tubes. So it's important, the dates of these tests. The only thing which she missed was when were those tests done. So we had to add, she had her hysterosalpingography done a year ago. She had 5 years ago, 6 years ago. Similarly, all these tests, they should be mentioned chronologically that on what date she had those tests. And similarly, it comes to treatment. She mentioned all the treatments she had, or possible treatments she could have. And if she had this induction of ovulation through clomiphene citrate, a drug taken from 2nd day to 6th day, that means clomiphene citrate generally. If she had clomiphene citrate, again, when was the last course? 8 is a long period. Maybe she had clomiphene citrate treatment 5 years ago, 4 years ago. So then it means this is very far in the history, so we could possibly repeat it. And similarly, all other treatments, if she had. And I would definitely request that you take this history as a model and go over it and repeat it when you're taking next history of infertile or subfertile couple. And once that becomes your part of the routine, then you will not miss anything in examination. And you should not fail when you get infertile couple. The treatment is so standardized and so easy to remember. If you make a flow chart, investigation, then according to those investigations, you prescribe the treatment. Husband has oligospermia, azoospermia, that's a different treatment. There's failure of ovulation. Treatment is induction of ovulation in various stages. Clomiphene citrate, Lesra, and then injectables. The lady did mention how clomiphene citrate was monitored by sonography. She could have used the word TVS. The sonography was done transvaginal route from below. Ask the patient, did you have ultrasound done by putting the probe on the abdomen or from below? She wouldn't understand TVS. That we understand. So, because TVS gives you better picture of the follicles than abdominal ultrasound. So, these are finer things which you can improve or add, but otherwise, this history scores instantly 6 marks. That means pass. That means pass. Only a few days ago, I was with some counselors of College of Physician Surgeons. I was really disappointed when one of them mentioned in a recent IMM intermediate module 270 odd candidates in our subject gynecology appeared. Have a guess how many passed? It was casually mentioned over a dinner. Have a guess.
200.
400?
200.
200 passed. This was the figure quoted. Only one. Only one. Others were all substandard. For God's sake, prepare yourself well. Why? When you fail, you're doing damage to yourself. It is to your disadvantage. Next is maybe your family, your husband, your parents, your children. Because when you're reading or studying, your children are unhappy with you. Mama, do this, do that. You say, no, get lost, I'm studying. They get upset about it. So the sooner you get over it, better it is. But this is terrible, terrible. By general standards, this was the result. And it's not only your subject. They mentioned another subject as well. So you people are not serious about your studies, about your preparation for FCPS examination. Just the fact this is a free class. The only something wrong with this class is it is at 8 o'clock on Saturday morning. It is free, you're made comfortable, you're served tea, and I don't shout at you that you feel that a teacher is always shouting at us. I don't want to go attend the class. I try to be friendly with you. I try to be polite with you. Still, how many of you have come? Hardly any. Hardly any. For me, even one candidate was good enough. I told her when I came, she was the only one sitting here. I said, it's good enough for me. I have taken this challenge of training only one candidate many times. Every one of those candidates have a story which I can narrate. And generally, story of success. Story of success. When one candidate was so poor, unbelievably. You can't imagine how poor one candidate could be, but she was that way. And once I was taking class 1-to-1. She didn't know a word of the subject, nothing. So I got so upset. I told her by name. I will not give you the name because you might recognize her. Now she is a successful gynecologist in this town. And I told her, you know, the day you pass, I will rush to Liberty Market, to a jeweler's shop, and buy a big gold medal and wear it myself. That was like winning a gold. So, and she passed. So that way, I'm quite happy even with one candidate. Although if there was none, I will be very upset because I love this activity. And so one is enough. But all of you, I'm telling you, for God's sake, take it seriously. This is a milestone in your life. Unless you cover this, you don't get on the other side of it, which makes you specialist, which you declare that you're a certified specialist. Unless you pass, you are a trainee. You are under training. So that status is totally different. You can't claim, doesn't matter how long your experience is, how old are you, you're still a trainee, under training. The day you pass, then you're no more a trainee. You're a certified specialist by College of Physician Surgeons. So get into that zone as quick as possible. Prepare yourself well. So I'm so impressed with this history. Shafi Saab, tell your mother. And after all, there's something related to genes as well. And I would want her to go over this history once again. And then, because after this history, there's very little we can discuss how shall we manage this patient. Okay.
Mrs. Noreen, wife of Mr. Ahmed, she is 34 years of age with no formal education, resident of Kasur. She is married for 8 years. She is nulliparous. Her last menstrual period was on 9th October 2019. She presented to Arif Memorial Teaching Hospital Outpatient Department on 16th October 2019 with complaint of inability to conceive for 8 years. The couple is married for 8 years. It is consensuous marriage and first marriage of the couple, and they are living together since start of their marriage. They practiced barrier method of contraception for first 3 months, but later did not use any. The coital frequency is 2 to 3 times per week, and every time the coitus have been satisfactory with no coital difficulty, and there is no history of dyspareunia or any post-coital bleeding. During the past 8 years, the patient and her husband have been through certain investigations as a part of their infertility workup. Husband semen analysis was done 1.5 years ago, and according to patient, it was normal. However, she does not know the sperm count, motility or morphology, and report was not available with her. Her tubal patency was also done via histosalpingography, and she claims that she had patent tubes. She was tested for ovulation by ultrasonography in mid-cycle, and a blood test was done on day 21 of her menstrual cycle, the name of which test is not known to the patient, but she was told that she is producing eggs normally. Up till now, she has taken treatment in the form of ovulation induction, as she told that she had used tablets during menstruation from day 2 of her menstrual cycle for 5 days, and every time she was given the same drug with same dose, and it was advised to her to visit on day 12 of her menstrual cycle for transvaginal scan for follicular tracking, and she was reassured that size of follicle is satisfactory. However, no further treatment options were ever discussed with the couple. She has no history of weight gain, acne or hirsutism. She has regular menstrual cycle of 5 by 28 days with average flow, soaks 2 to 3 pads per day, no history of dysmenorrhea or intermenstrual bleeding. There is no history of heat or cold intolerance. no history of headache, blurring of vision, or any abnormal nipple discharge. There is no history of any excessive vaginal discharge, lower abdominal pain, or fever. No history of regular drug intake or radiotherapy or chemotherapy in past. There is no history of sub-fertility in any family member, and she has never had any surgery. Her husband is 38 years of age. He is non-smoker, non-addict, owns a business of garments. There is no history of any medical illness, any surgery, trauma, or drug intake in husband. Now, the couple has presented to RF Memorial Teaching Hospital for re-evaluation and further treatment for their sub-fertility.
Go on. Rest. I stopped you here, but we now go on.
So regarding her past gynecological history, age of menarche was 14 years. She has regular menstrual cycle of 5 by 28 days with average flow. No history of dysmenorrhea. Patient had practiced barrier method of contraception for the first 3 months, and pap smear was never done. Regarding the past medical and surgical history, there is no significant past medical surgical history. There is no family history of sub-fertility or any hypertension, diabetes, or ischemic heart disease. Regarding her personal history, she has normal sleep and bowel habits. There is no history of smoking or any addiction, and no history of any known drug allergy. Now, her general physical examination, a young lady sitting comfortably on couch, answering to the questions intelligently. Her weight is 60 kilogram. Height is 5 feet 2 inches, that is 157 centimeter, making her BMI 26 kilogram per meter square. There was no pallor, jaundice, cyanosis, clubbing, koilonychia or leukonekia. No accessible lymph nodes or thyroid was enlarged. There was no edema. Her vitals are blood pressure is 110 over 80 millimeters of mercury. Pulse is 86 beats per minute. Temperature is 98 degree Fahrenheit, and respiratory rate is 18 breaths per minute. Breast examination. Breast is symmetrical with normal nipple and areola complex. There is no mass or lump palpable in any quadrant, and there was no nipple discharge. First and second heart sounds were audible with no added sound. There was normal vesicular breathing with no added sound, and regarding her CNS examination, her GCS was 15 by 15. On abdominal examination, the abdomen is normal looking. It is slightly protuberant in the lower abdomen with central umbilicus, moving with respiration, and there was no visible scar marks, stretch marks, stria, or any visible pulsation. On pelvic examination, vulva, vagina, external urethral meatus are normal looking with normal hair distribution. No blood or discharge was seen coming out of the introitus. On Cusco's speculum examination, lateral vaginal walls are normal looking. There is no pathological discharge or bleeding seen. Cervix is normal looking, and there is no local pathology. On bimanual examination, uterus was of normal size, anteverted, mobile, and bilateral fornices were clear. And at the end of examination, no blood was seen on gloves.
Very good. Very good. All the aspects. Okay, first I'll make a short comment about your general physical examination was fine. As gynecologists, we are particularly interested in abdominal examination. And what you described about abdominal examination was on inspection. On inspection, how the abdomen looked and everything. No stria, no scar. But generally, in examination, you are expected to describe abdominal examination on inspection, palpation, percussion, and last of all, auscultation. Generally, all these aspects have to be covered. But today, because of infertility, she didn't expect anything more than what she described on inspection. Still, I would say for a very good history like this, add on inspection, this, what she described, on palpation. In such patients, you can add on palpation, no tenderness anywhere, because it could be on inspection abdomen looks normal, but there is tenderness somewhere, and no tenderness and no visceral enlargement felt. That means on palpation we are looking for enlargement of liver, spleen, and low down uterus or ovaries or ovarian cysts. That you will find only on a palpation. On palpation. And in this case we'll stop at palpation, but if there is a mass anything, then you should add percussion, that is for fluid in the peritoneal cavity. Whether there is dullness in the flanks or dullness anywhere, and if you're suspecting fluid or ascites, whether that fluid is shifting dullness. And so you have to, the auscultation generally we omit unless it is obstetrical case. There, last of all, auscultation also comes in obstetrical patient. You describe on auscultation. In a gynae patient, auscultation will come very rarely. You don't have to. You don't have. For us, auscultation would be required in a gynae patient, where you want to see if there's aneurysm of the aorta or any sort of bruit or any abnormal sounds in the large blood vessels. That will be rare. Most unlikely in the examination for you. So we can omit auscultation, and we can say that even percussion can be omitted, reverse order I am saying. And but if you suspect there is fluid, only then you will do percussion. Otherwise, first inspection and palpation. You didn't palpate. Well, palpation has to be added to your examination. And third thing, on vaginal examination, you said cervix looks normal. Here you can improve because this is a very good history. That's why I'm saying that will be accepted normal. But because she is nulliparous, she has never been pregnant. So nulliparous cervix is different from those who had been pregnant previously. Their cervix is split into anterior lip and posterior lip. Nulliparous cervix is circular. And you can, as a good candidate, you can say in this patient, cervix is nulliparous and no ectopy. You'll get extra marks. When you say no ectopy, that means you're telling the examiner squamo-columnar junction is at the external os. I was most impressed when she said on withdrawal of the fingers from the vagina, there was nothing on the finger stalls. Normally we don't look at it. She did. Very good. And so you describe, after finishing the examination, I inspected the gloves, and there was no extra discharge or blood on those. In examination, after speculum insertion, you will be required to do pap smear. Here you can add in this patient, after inspection of the cervix, I took a smear for pap smear examination. If you are a good candidate, the examiner may ask you different grades of pap smear. 1, 2, 3, 4. What do you see in 1, 2, 3, or 4? 1 is absolutely normal. 2 has inflammatory cells in that. 3 has suspicious cells, suspicious malignant cells. 4 degree is no suspicion, definite malignant cells. So just in 10 seconds you can answer this. Okay, when you've done all this, finish, the next question will be, examiner will ask you, okay, what investigations will you do in this patient?
So first of all, I will review the investigations with date that have already been carried out in this couple. So if need be, they can be repeated. If the duration is long, then the husband semen analysis and patency test can be repeated. Further, I will counsel the couple that most of the patients...
I will. This is okay. I'm just trying to improve every aspect. I'll review those investigations with dates and also note where those investigations were done. This is for your practical, in your practice. Because in our country there are so many laboratories which are not so reliable. So I will review those reports and also observe or note where those investigations were carried out and how long ago, as you have said. Then in view of that, all those investigations, if they are satisfactory in examination, they will be satisfactory. Don't go into the I trust this report, I don't trust this report. No, if they are presented to you, they are normal, we'll proceed further. In examination, practically all the reports presented to you will be said. So you will not criticize the status of the lab or the hospital. If it says normal, you accept normal. But in practice, be sure where that ultrasound was. So many patients, you must have seen during a training that they had some investigation like ultrasound. And patient told she has cyst, she has fibroid, she is this. When you do get it done properly, there is nothing like it. So many patients come to me in my practice diagnosed as ovarian cyst. When I get the same ultrasound done here, there is no cyst. No cyst. Similarly, so confirm whether the reports are reliable. They are satisfactory. So we say all those reports have been done and they are satisfactory. What will you do in this patient?
So I will counsel the couple that the investigations that have been carried out in this patient are normal, and most of the patients have unexplained sub-fertility. I will discuss and give options to the patient and her husband about.
In this patient, we haven't had her what we call routine investigations as yet. You haven't told us that her hemoglobin is normal, her urine test is clear, and her blood sugar test is been done or not done. So if the patient didn't give you that history, in investigation, you have asked all this, they are normal. Still, we like to do the health checkup. I call it health checkup, which you must do. That will be CBC. Hemoglobin, generally you will find low. Our nutrition is such, patients who have menorrhagia, they hardly notice this because anemia gradually develops. And of course, thalassemia is also quite rampant because we haven't taken measures to eradicate that. So you will say, your first will be, I'll do her health checkup. How? CBC, blood sugar, and of course blood group as well, and urine test, all these investigations. So these will be the first. Now all those are normal and the patient had these investigations. Then what will you do?
So I will counsel the couple that the investigations that have been carried out in this patient as a part of infertility workup are normal. I will counsel them that most of the patients have unexplained sub-fertility.
Mostly this patient. I'll counsel her that you have sub-fertility which the cause could not be detected by these investigations which have been carried out. We label it as unexplained. In so many words, we will counsel our patient that she has unexplained infertility or sub-fertility. Invariably the patient asks, after all these investigations, still you don't know the cause. What will be your answer?
Sir, that most of the couples...
You counsel me that your sub-fertility is unexplained. And I ask you, you have done so many investigations, presumably you have done it. Previously all these tests have been done and nobody tells me why I am not having babies. What will be you say?
So we will counsel that in most of the patients the cause of infertility is...
Forget about most, talk about me. That in your case, by the tests available to us, we have not found the cause. That's why we say unexplained infertility. However, there are certain sophisticated new tests which are available by which we can pinpoint, maybe we can pinpoint the cause. But those are not available for routine investigations. A good candidate like you should say this. So counsel me again.
Regarding the investigations that we have carried out as a part of your infertility workup, no cause have been identified and this is known as unexplained sub-fertility. However, certain specific investigations are available to rule out the other minor causes of infertility, but they are not available.
They have not been done not been done and we don't know. What are those investigations? Being good, this is the disadvantage. This is the disadvantage. It's not written in your book. If you are doing well, then be prepared that you will be asked questions like this. Okay, the causes which are possible to be investigated or found out are the type of egg, ovum she is producing, to capability of spermatozoa to fertilize, and these can be found out in IVF lab, where you pick up egg from the wife, put it with the sperms of the husband, and next day you observe whether fertilization has taken place or not. If there is fault with the egg, like tough zona pellucida, or fault with the sperms, they don't have the capacity to penetrate into the egg, then fertilization will not take place. So, if the patient insists, tell me. The answer is that further investigation can be done in the IVF lab by finding out whether the egg can be fertilized by the sperm of the husband. If there is failure of fertilization, then you put egg with somebody else's sperms and husband's sperms with somebody else's egg. Then you can pinpoint whether fault is with the egg or with the sperm. So because she presented so well, I'm taking you into that territory. Otherwise, normally your examiners don't know this, generally speaking, and you will not be asked. But if you are doing so well, you may be asked. So to remain one up, you should answer. So this is unexplained sub-fertility or infertility. What else can be done to find out? So you can say there are special tests which are carried out in IVF lab, where we can find out capability of the sperm to fertilize the egg, or the quality of the egg, whether it can be fertilized by sperms. Fault could be with the egg, fault could be with the sperm. If the failure of fertilization takes place, then further, who is responsible for that failure? Egg or sperm? It can be by cross fertilization with somebody else's eggs. But those eggs which are fertilized like this, they are not used for pregnancy. That is for experimental purposes. That is for investigation purposes. But this is the way we can find out. Okay, you will counsel me about all the investigations which have been done. Okay, what are you going to do for me? What is your plan?
Sir, I will give options to the patient. After proper counseling of the details of the procedure, the approximate cost of the procedure, the success rate, and the possible complications of that procedure. I will give option to my patient about in utero insemination with ovarian stimulation. I can explain to my patient that we can go for 2 to 3 cycles of IUI, in which the husband semen analysis will be taken and will be prepared in laboratory, and good motility spermatozoa will be taken, and after then it will be loaded in a catheter and will be injected in the uterine cavity, so that any hostile factor in the cervix or vagina can be
and on the day of
ovulation, and it will be injected on the day of.
Prior to that, her ovulation will be monitored, or even before that, clomiphene citrate will be given to stimulate ovaries to produce more eggs. So, right from the beginning. In your case, the options are, because you already had clomiphene citrate courses, I'll omit those. If she says, oh, that course was taken by me 4 years ago, 5 years ago, then you can still start from clomiphene citrate. You're presuming that she had clomiphene citrate recently, so move on. So I'll ask her, when did she have last induction of ovulation with clomiphene citrate? If it was long time back, then I can repeat that. I can repeat that. How, if you give clomiphene citrate to her, how will you manage that patient or monitor that patient?
After ovulation induction?
Just simple ovulation.
Sir, I will counsel the patient that she has to take the medicine during menstruation, starting from the day 2 of her menstrual cycle for 5 days, and to monitor her symptoms if she has any nausea, abdominal pain or bloating, and then I will advise her to visit on the 12th day of her menstrual cycle, so that a TVS can be done to determine the size of the follicle.
Very good. What will be the size of the follicle, which will decide whether she is good candidate for IUI or not?
So it should be around 18 mm to 20 mm.
Good. And if she achieves that size, what will you advise her?
Sir, I will advise her in utero insemination.
No, not necessarily. First thing is we are giving only stimulation. So you'll advise her to live normally,
Normally, yeah.
have coitus for 2 to 3 days. Full stop. So our first line of action will be, depends when did she have last course of ovarian stimulation. If it was long time back, then I'll start with ovarian stimulation. It is called controlled ovarian stimulation. Controlled. How? First giving the drug, then monitoring by TVS. If she is ripe, then advising them to live normally for next 2 to 3 days. Suppose she doesn't become pregnant, then what will you do?
If she doesn't become pregnant with simple ovulation induction, then I will give further options to the patient that we can proceed to.
These are practical things. If she doesn't become pregnant, then I'll review what was the response to clomiphene citrate or induction of ovulation. Because if she had follicle of 20 millimeters, it means the response was good. After all, those who become naturally pregnant, it's not their wife is ovulating every month, but the young married couple may take 6 months or 1 year to become pregnant. So ovulation doesn't necessarily mean pregnancy. So here, if she takes induction of ovulation by clomiphene citrate, on monitoring, the follicle size was achieved, but still not pregnant, we'll repeat it. I'll ask her to repeat 2-3 times. However, if after giving clomiphene citrate there is no response, follicle does not reach the desired size, then either I'll increase the dose of clomiphene citrate. Initially we give 50 milligrams per day. I'll double it or triple it. And then monitor again by TVS. If she, with 50 milligrams she did not achieve the size, with 100 milligrams she does. So we'll repeat that for 2-3 cycles. However, if she does not achieve the size, even after going up to 150 milligram, that means 3 tablets a day, then I'll switch over to Lezra or even injectables. I will change the regime of stimulation. So our criterion of failure of stimulation is not pregnancy. Our criterion for giving up clomiphene citrate is failure of achieving follicle size of 20 millimeter. Important. So first thing is, if she achieves the size, we'll persist with that treatment for at least 3-4 cycles. If she doesn't, increase the dose or change the drug. And if in spite of that she doesn't become pregnant or we don't have the ovulation, then we move on to IUI, intrauterine insemination.
So you continue your
Intrauterine insemination. And there again, the regime is for intrauterine insemination, stimulation of the ovaries in the same fashion, either with clomiphene, 50 milligram only, increase the dose to 100, 150 or 10. And then after TVS, if we find right size, here we give injection of HCG to induce, to shed the ovulation, and next day after 24 hours we do insemination as the lady described, by preparing semen in the lab, separating active sperms and injecting through the catheter into the uterine cavity. That is known as IUI. We'll repeat IUI 3 to 4 times. Success rate is only 10% of IUI. So everybody doesn't become pregnant with IUI. If IUI also fails, then you go on to the next IVF or ICSI, intracytoplasmic sperm injection. ICSI we call it, ICSI. Very briefly, IVF is same stimulation of the ovaries, monitoring it not only once, repeated, because it's an expensive treatment. We have to be very sure. Repeated TVS, on the right day injection of HCG. Then after 36 hours, what we call OPU, ovum pick up, transvaginally, ultrasound guided. Add sperms to those eggs. Then after 2 or 3 days, those eggs which are fertilized, they are transferred into the uterine cavity. These days, single embryo transfer is favored. It is called SET, SET, single embryo transfer. Rest are, if you have facility, cryopreserved or frozen for future use. After you've done embryo transfer, ET, we provide hormonal support during next 14 days, which is called luteal phase support. Generally progestrogens or progesterone. Then if the test becomes positive, you continue luteal phase support for nearly 20 weeks. If the test becomes negative, then luteal phase support is stopped. And test is generally done through checking up beta HCG, because beta HCG is much more blood beta HCG, because it is much more sensitive than urinary beta HCG, which comes positive after few days than blood. If failure takes place, I have already told you, failure could be due to lack of fertilization. So then either you investigate further why lack of fertilization, or if fertilization took place, then you investigate endometrium, why implantation did not take place. For that, a special test has come into practice very recently called ERA, which tells you what is the exact date of embryo transfer or implantation. I have given you too much detail because we finished too early with the history. So I repeat, if a patient like this comes to you and you have not found any cause of infertility or subfertility, first the lady said, I'll counsel my patient. Very good. You should counsel her that we have investigated you, we couldn't find the cause. This is called unexplained infertility. If the patient says, for God's sake, find the cause, you will say, yes, there are now tests available, but they are very expensive. They are done in IVF lab to find out whether the fault, in the case of unexplained, whether the fault is with the egg or with the sperm. That can be diagnosed in the IVF lab by finding out failure of ovulation, whether egg is responsible for that or sperm is responsible. We can say husband is responsible or wife is responsible. Then we come to, how are you going to manage me then? We'll say, when did you take last induction of ovulation? There is infertility for 8 years. If it was many years ago, we'll start again with clomiphene citrate. Low dose, no response, increase the dose. Monitor by TVS. If follicle is 20 week size, tell the couple to live together normally, have coitus. If we don't achieve follicle size, increase the dose or change the drug or go on to gonadotrophic injections. But the regime remains same in this patient because everything is normal. If in spite of 2 or 3 trials, natural pregnancy does not, it will be natural pregnancy by coitus, living together normally. If natural pregnancy does not take place, we switch over to IUI. Stimulation regime practically similar. But here, if the follicle size is achieved, we give HCG injection to induce ovulation, shed over, and then after 24 to 36 hours do IUI after special preparation of the semen. Success rate 10%. If it doesn't succeed in 2 or 3 attempts, then we move on to IVF or ICSI.